And again, I'd like to thank Enzo for the opportunity to be here. I want to thank his entire family and the Cisco staff for all the hard work to put this really excellently run meeting together. The case that I'm going to present is an EK case. This is a 51-year-old, very high myope, axial length 28 millimeters. She had a history of spontaneous retinal detachment when she was in her 30s. This was repaired with pars plana vitrectomy and endolaser. She then developed a secondary post-vitrectomized cataract and had uncomplicated cataract surgery. Comes to my clinic at 51 years of age with a history of better than 20/20 acuity following her prior trauma, and now has central guttata, early corneal edema, and she's very disabled when trying to drive to and from work. So the patient obviously needs an endothelial replacement. The question is, which approach are we going to use? And so for the first question, for surgeons who routinely do both DSEC and DMEC, which procedure do you feel in your hands provides superior outcomes? Do you feel it's DSEC? Do you feel it's DMEC? Or do you feel there's no difference? Yeah, so this mimics my own view of how to approach patients. Whenever I can do DMEC, I certainly do it. So in this case, which procedure are you going to perform? This is a very high myope with a large anterior chamber, long axial length, post-vitrectomy. Is this a DSEC or a DMEC procedure in your eyes? Yeah, so this is, in my hands, I'm less excited about DMEC in this patient, so I'm glad to see there's some ambitious DMEC surgeons. Let's now ask the patients or the surgeons who chose DSEC, the 40% that chose DSEC. Did you choose it because you thought it was going to provide a better general overall outcome, or did you choose it with the idea that you would like to do DMEC, but the specifics of this case make unfolding the graph too difficult, and therefore you want to move ahead with a DSEC? So that's exactly how I perceive this, and what I want to talk to you about today is a study that our fellow at the Cincinnati Eye Institute, Dr. Kurji, did comparing visual outcomes in cases of primary Fuchs dystrophy with no comorbid conditions that were treated either by Dr. Holland using nanothin DSEC or by me using DMEC. No financial disclosures. So again, there's been a large body of literature that suggests that DMEC is actually superior to DSEC, and I think most of us who do both certainly feel that. The issue is that many of the studies that are comparing the two are older and really are referencing DSEC procedures when the graphs were much thicker than they are now. And the fact that thickness is an issue has been documented in a number of areas within the literature, but Busen certainly published that ultra-thin DSEC graphs that were under 100 microns could achieve outcomes that were similar to those published by others using DMEC. So in this prospective study, we are looking at nanothin DSEC, and Ed Holland, who is here, is going to discuss a little bit more in detail that aspect of it. But these are very thin graphs. Ed worked with the Minnesota Lions Eye Bank to be able to obtain graphs that were less than 50 microns or 50 microns or less for his DSEC procedure. Again, prospective case series, 28 eyes in each arm. The DMEC procedures were performed by me. The DSEC procedures performed by Dr. Holland. Again, these are simply Fuchs patients, plus or minus cataract surgery, but no other comorbid conditions and at least 6 months follow-up. The outcomes were visual acuity and intraoperative and postoperative complications. The demographic analysis of the two arms are identical with regard to mean age, gender, central corneal thickness, and the postoperative follow-up. So visual acuity results in the solid bar is demonstrated here for DSAIC and in the dashed line for DMEC. And you can see at 1 month that the DMEC provided better visual acuity, and that was statistically significant. At 3 months, there was a 10 towards better vision in the DMEC group, but that was not statistically significant. But by 6 and 12 months, there really was an indistinguishable visual acuity difference between these two procedures. If you look at the percentage of patients that achieve 20/25 vision or better, you see the preoperative visual acuity again is very similar between the two groups. DMEC is shown in the dashed line, so at 1 and 3 months, a much larger percentage of patients had 20/25 acuity or better. But by the time, again, we get out to 6 to 12 months, the difference between these two procedures seems to abate. There were no statistically significant intraoperative complications or rebubbling rates. There was 1 rebubbling in the DSAIC group, no rebubblings in the DMEC groups, and neither group had rejection or other postoperative complication. So, while I still feel DMEC is a better procedure, it's the anatomical, recreation of the normal anatomical result, and so I certainly try and do it. I feel less guilty in these more complex patients when I do feel that it's easier to perform DSEC and get them a good result the first time round. And as long as we're using very thin tissue, I think we can offer patients both of these surgeries. Thank you.